I will be presenting some milestones during my career, and inevitably I will be biased in favor of the topics in which I think I played some positive role. I will be discussing elements of research that led to established practice, but also those that did not, and raise the possibility of the factors that prevented their clinical implementation. Now, about 1 to 200 million years ago, the world was dominated by dinosaurs. But most of you believe that these were extinct about 65 million years ago. I believe they are alive, and they are here, and they are everywhere, and they will live forever and ever. I will illustrate some of the elements of the evolution in clinical practice, and as an example for the detection of fetal abnormalities, I will refer to that of spina bifida. Here is a young Stuart Campbell holding a lethal instrument and describing in the early 1970s what he and nobody else could see, the diagnosis of anencephaly and spina bifida. It was so convincing, the argument, that throughout that decade and beyond, the method of screening for spina bifida was second trimester maternal serum alpha fetoprotein. And then, by accident, we found that you could, by not looking at the spine, strongly suspect the possibility of spina bifida, and you did not need any sophistication in order to do so, but you could all undertake this investigation, and I think that that was the push into replacement of maternal serum alpha fetoprotein with ultrasound as the primary method of screening for spina bifida. And 10 years later, we have Rabbi Chawi shifting ultrasound in this example, but in many others, of course, into the first trimester of pregnancy. And here we have a publication on more than 100,000 pregnancies of what is now feasible to diagnose in all cases, in some of the cases, or never, in respect to the first trimester scan for the diagnosis of fetal abnormalities. In the United States, the American College of Obstetricians and Gynecologists, that are women's healthcare physicians, in 2003 said that the method of screening must be maternal serum alpha fetoprotein, and they did not change their mind until about Christmas time 2017, the 31 wasted years. Evolution in screening for chromosomal abnormalities, best illustrated here from the method of the 70s, based on maternal age, to that of the 80s, second trimester serum biochemistry, and the 90s, the first trimester combined test. If you could read the references at the bottom, you will see that in 1998, we published in The Lancet a study involving more than 100,000 pregnancies, and the year was 1998. You see dinosaurs are everywhere, right? In 2002, the UK National Screening Committee said we must continue to screen with the second trimester biochemical method, which has a detection rate of 60% at a false positive rate of 5, rather than the method that on 100,000 pregnancies was shown to detect 30% more. Under the pressure of women's groups, and nothing to do with physicians, the government was forced to change its mind, but after 16 wasted years. In 1998, Dennis Law suggested that you can find cell-free DNA in the mother's blood that comes from the placenta. And then in the early 2010, in collaborative research, we demonstrated that with this method, you could perhaps identify more than 99% of the cases of Downs at a false positive rate of less than 0.1%. And in subsequent implementation studies, this was shown to be the case for Downs, not only in singletons, but also in twins. The real question is how to implement this method for the whole population. We proposed that we should be doing so at the back of the first trimester assessment of the pregnancy, identifying a subgroup at very high risk that should only have an invasive test, let's say those with a risk of 1 in 10, because the nuchal translucency will often be more than 3.5 millimeters, and in that subgroup you will have a lot more things than just Downs and a couple of other things. At the other end of the spectrum, those with a risk of less than 1 in 1,000 perhaps could be reassured with just an additional ultrasound scan in the second trimester of pregnancy. And the cell-free DNA test should be provided to the intermediate risk group, where we have the greatest confusion in terms of their management, to help define those that will need and those that will not need to have an invasive test. As always, with new technologies, we are the victim of propaganda, and a lot of our knowledge is acquired in the booths exhibited in various congresses from different companies. And you have the inherent ideology of the more, the better. But of course, that is completely true, and it goes a long way into us reinforcing what you have heard so eloquently from the previous lecture. I believe that the only scientific evidence in relation to cell-free DNA testing and its worthiness relates to trisomy 21, and trisomy 21 and Down syndrome alone. I will now move to intrauterine therapeutic interventions. And the great, that's nice. Okay, good. Let's go back to the beginning. I know that you want to hear the same part of the lecture again. Okay.
So maybe we get the overview.
Where do you go?
Can you take that? Yeah, there you are.
Okay.
Yeah, that's fine.
The great leader, the initiator of this whole field, is of course Liley, that in the 60s suggested that we can assess the severity of fetal anemia by looking at the amniotic fluid to see how yellow or green it was. and then introduce a needle into the fetal abdomen and infuse donor blood. Unfortunately, in the absence of ultrasound, the mortality rate for early gestations was nearly 100%. In the 1980s, we rewrote the concepts in relation to the prediction, assessment, and management of red cell immunization through the introduction of fetal blood sampling that was now defining the degree of severity of the condition on the basis of their fetal hemoglobin concentration. We learned how fetal anemia looked like, 10 ascites, dilated heart, not pleural effusions, not generalized edema until after you die. You develop those. And subsequently, using invasive testing, we validated non-invasive techniques like Doppler, and the first Doppler studies in the department of Professor Campbell were done in defining the relationship of hemoglobin concentration in the fetus with various Doppler indices. Okay. Okay. In the 1990s, also with the introduction of the first trimester scan, we have two important people. We have the Sepulveda that described the lambda and the T signs in the 12th week of pregnancy as a method of defining chorionicity, and Niels Sebier in highlighting the great importance in distinguishing between monochorionic and dichorionic pregnancies, and this classic paper on the hidden mortality of
Oh my God.
I told you there are so many dinosaurs everywhere. What can I do? Maybe I'm incompetent in
behind there.
Yeah.
And it was called the hidden mortality because in the previous era that we did not have a first trimester scan, these women, by accident or the desire of the gods, were miscarrying by the 20th week of pregnancy, and therefore they did not exist. That created a new era in terms of the prediction, assessment, and management of monochorionic pregnancies. And we found that in women, I should be pressing this, thank you, okay. Okay, okay. I skipped something. Let me go back to this. It was that era that by ultrasound you saw something that looked black, and it was not a very good thing to have in any part of your body. If it was in the head, you put drainage tubes in the head. If it was in the chest, you put drainage tubes in the chest. And if it was in the lower part of the abdomen, you put drainage tubes in the bladder. 40 years later, we know that it is useful in pregnancies presenting usually with polyhydramnios at around 26 to 28 weeks, and pleural effusions to introduce shunts in that, and it is not useful at all to put drainage tubes in any other part of the fetus. Right. That is where I was talking about Sepulveda and Sebier and the hidden mortality of monochorionic pregnancies. And we found at that time that if at 12 weeks you had a very high discordance in the crown rump length between the two fetuses in monochorionic twins, or a high nuchal translucency in one or both of the babies, you had a much higher chance that by the 16th week of pregnancy, you would either have miscarried or you would have developed severe twin-to-twin transfusion syndrome or selective IUGR. That was somehow questioned by meta-analysis, and I will come to this new disease in obstetrics, gynecology, and medicine. We have in more than 6,000 twin pregnancies just now, confirmed the results of 400 pregnancies in the early 1990s, that there is a massive difference in the lethality rate between dichorionic, monochorionic, and more so monoamniotic twin pregnancies. And this is particularly high in monochorionic pregnancies with a large discordance in the crown rump length between the two babies, or if one of the babies or both had a high nuchal translucency. And here are two extremely important people that were there in the early 1990s, and they took this whole field of assessment and management and endoscopic laser surgery for twin-to-two transfusion syndrome, Eve and Kurt. And that remains the method of choice for treatment of this condition and also selective IUGR. One of the great inspirational figures like Campbell in ultrasound was, of course, and is, Michael Harrison in fetal surgery. A very courageous pediatric surgeon that went against the interest or the apparent interest of his profession to introduce the concept of fetal surgery at the dismay of many, many other pediatric surgeons. He tried, as he would, translate the techniques that he learned in postnatal surgery into prenatal surgery, and inevitably that took us through the period of open hysterotomies and open fetal surgical repair. However, it was with Jan and Edward Gratakos that one day we manipulated through informed consent a poor infertile Cypriot woman in her 40s and a baby with severe diaphragmatic hernia to have the endoscopic approach to surgery for the insertion of a balloon into the fetal trachea, and that remains the method of investigation at the moment, and hopefully at some point soon we will know whether this is effective or not. In the meantime, we repeat with every new technique the same learning of the same lessons, and inevitably, when you introduce fetal surgery for spina bifida, you have to go again through the process of hysterotomy, but see whether these babies are walking and they are not incontinent of urine or feces. Short-term outcome measures are not really so important. But inevitably, if this is going to be a method of treatment, it has to be the fetoscopic approach. 3 of the people that produced this Nature paper in 1953 got the Nobel Prize, 2 of them, for the work, as always, of the poor guy in the middle, Leslie Brent. And what did they show in 1953? That if you take a pregnant mouse with a baby inside it, well, a little mouse, that is immunologically immature, and you inject foreign cells, the immunologically immature baby will develop tolerance to the foreign body. In 1986, in a case of severe Rhesus disease, where the woman succeeded in somehow killing a lot of her babies, we decided to do intrauterine marrow transplantation to change the blood group of the baby, and we failed. Baski, when he was a fellow, was involved in defining the gestational age at which the fetus becomes immunologically competent, and we went as back as the 12th week, and we found that already it was. So when we tried again an intrauterine marrow transplantation at 12 weeks, we failed to establish a chimera. At that time, the guy that spoke just before us Davor was at King's, and we wrote a paper in the Lancet in 1993 that was a failure. It was a failure because we established that you could obtain a sample from the coelomic cavity, but it was a failure because the cells that it contained were so very, very few that you could not truly do prenatal diagnosis with this type of samples. But George Makridimas in Greece has continued to develop this technique, and now using IVF type of techniques, you can pick up individual cells from this cavity, and he has demonstrated that you can establish successfully a 6 to 8 week prenatal diagnosis of thalassemia. Whether this will become a target for intrauterine transplantation at that very early gestation remains to be seen. Let me now move to another area, and that is where fetal medicine meets and hopefully should have replaced traditional obstetrics. This is another picture of my teacher in 1983. To make it easier for you, that sounds like 36 years ago, when he suggested that the impaired trophoblastic invasion of the maternal spiral arteries that are responsible for fetal growth restriction, stillbirth, preeclampsia, could be visualized by Doppler. And in subsequent studies, we established that abnormal uterine artery Doppler is associated with increased risk for fetal growth restriction and adverse pregnancy outcome and preeclampsia and stillbirth. That is 36 years ago. We now know that there are 3 types or periods of stillbirth with different pathophysiological mechanisms. We know that the stillbirth that happens before 32 weeks, in its vast majority, is a consequence of impaired placentation, either small for gestational age babies or preeclampsia. We also know that at the other end of the spectrum, after 37 weeks, only a quarter of the babies that die are small, another quarter are big, and another half are in the middle. We are fortunate enough in England to have had elections for the Prime Minister where a health minister that was competing for the premiership lost because he was a failed health minister as well. Recognizing that in England we are at the forefront of stillbirths in Europe, he proposed this fantastic scheme so that England becomes an empire again, and you have the lower rate of stillbirth within 20 years. And he said that the best way to do so is to reduce smoking in pregnancy, that was shown not to reduce the rate of smallness, is to make people aware of reduced fetal movements, that in the Lancet last year was published that it did not reduce stillbirths, but it succeeded in increasing the cesarean section rate, induction of labor rate, and neonatal unit care admission. He said that we must learn how to learn CTGs. I was a student 1,000 years ago, and they were training us on how to look at CTGs, and every week they tell us that we don't know how to read CTGs. In the next 2,000 years, they will be teaching us how to read CTGs. There must be something wrong with this technology that nobody can ever learn, and we must continue to learn and learn and learn, and we will continue to fail to understand. Risk assessment for fetal growth restriction, and I will come back to that. That is very important. And we must reduce preterm birth by creating preterm birth clinics for the high-risk group, and the very high-risk group contributes about 15% of the preterm births. They will fail. There is no mention of ultrasound within any of these guidelines. After 16 years of developing a methodology, we established that in the 12th week of pregnancy, if you add into the computer a few questions from the mother, and you measure the uterine artery pulsability index, and you learn how to measure the blood pressure properly, and you do so, and you put a tick next to the form where you ask for free beta HCG and PABA that says PLGF, you can, in the 12th week of pregnancy, identify 90% of the women that will develop preeclampsia requiring delivery before 34 weeks. And about 75% of those that will develop and result in delivery before 37 weeks. The National Screening Committee in England, with the NICE guidelines, I think NICE, they call themselves the people of excellence, and the American College have decided that we must continue to ask people 10 questions, and on the basis of these 10 questions, allocate the people into high or low risk. They insult the medical profession and they insult technology by suggesting that you are incapable of using computers, and they insult the ideology of personalized medicine by classifying people as terrorists and the good guys. Yes, no. This method of screening has been compared head-on in a study in 7 hospitals in England, funded for the first time in my career by the NHS. And in this study, we found that the first trimester combined test has exactly double the detection rate as that of the NICE guidelines. We went on to screen in several European countries more than 26,000 women using this methodology, identified the 10% highest risk group, and randomized them into 150 milligrams of aspirin per day from 12 to 36 weeks. And we found that with this approach, we can reduce the rate of preeclampsia before 32 weeks by 90%, before 34 weeks by 80%, preterm preeclampsia by about 60%, with no impact on term preeclampsia. We also found that this is highly cost-effective because the biggest expense in obstetrics is not obstetrics, is in neonatology. And by dramatically reducing the risk of severe premature birth, you are dramatically reducing the length of stay in neonatal intensive care. We deliberately published most of these papers out of spite in American PEP journals, the New England Journal of Medicine and the American Journal of Obstetrics and Gynecology. The women's healthcare physicians and the high-risk pregnancy experts, in a hysterical outburst last year, after this publication, said there must be only one method of screening, and that should be based on maternal risk factors. We must continue to give the suboptimal dose of 81 milligrams, and you must give it to anybody that happens to come to the toilet of the antenatal clinic at any stage in pregnancy. When we know, and you have demonstrated successfully, that for aspirin to be effective, it must be given to a high-risk group before 16 weeks and at a minimum dose of 100 milligrams. Let me turn now to smallness and fetal growth retardation. We and others have established that 85% of small for gestational age babies are born at term. Universal not selective third trimester scan is the methodology of identifying the small for gestational age. The use of the estimated fetal weight as per Hadlock rather than just the abdominal circumference is the method of assessing fetal growth. We have found that the 36-week is the gestation for the third trimester scan, not 32 weeks. And unfortunately, we found that there is no additive value from growth velocity or the use of placental growth factor, FLEET, CPR, and uterine artery pulsatility index. In England, in these megalomaniac plans to reduce stillbirths, they suggest that the new technology to be used for assessing fetal weight is to use a measuring tape. An extremely important component of assessing fetal growth is to understand, as Marsal understood a few decades ago, something very weird. We assess the weight of a fetus, we deliver it immediately, and more or less we get it right that the estimated fetal weight is the same as the birth weight. Then you do an ultrasound scan, and you plot the measurements on the estimated fetal weight chart. It is on the 5th centile. You immediately deliver the baby, and you plot the measurements on the birth weight charts, and the baby is macrosomic. Because we failed to understand that birth weight charts use babies that were born prematurely, and since prematurity is a pathological condition, you cannot use a pathological condition to produce normal ranges. And we continue to discuss intergrowth, WHO, all sorts of graphs that fall into the same mistake of not recognizing the necessity of joining up estimated fetal weights with birth weights. A mathematician, and therefore not prejudiced by dinosaurs, obviously found the simple answer, and that was David Wright, that says the midline that defines the relationship between gestation and birth weight or estimated fetal weight must be identical. In the 1980s, Peter Soothill, when we were on the 9th floor of King's, used to take some of the fetal blood that we were collecting from babies with smallness or exomphalos to diagnose chromosomal abnormalities or not, and he was running down to the 8th floor and he was measuring blood gases. And in that era, we established, to the dismay of animal physiologists, that birth asphyxia can precede labor and is not necessarily due to the process of birth. It was the era where we were on a daily basis being told off if a baby was born asphyxiated by neonatologists that it was our fault. When we submitted this paper for publication in the BMJ, they told us, but this is wrong because in animal studies it does not work. And because I was young and excited, unlike now that I'm very, very mature and relaxed, I picked up the phone and I quarreled with the editor of the BMJ and I said, I don't care if you choose to be an animal. In humans, this is what we found. Of course, that established a whole era where we defined that fetuses are starved with the same biochemical, endocrinological, hematological profile as children with kwashiorkor. We thought we could cure the disease by giving these women oxygen. But because I'm a very heavy smoker, I was very liberal with those women that were also heavy smokers. So they would have oxygen masks for a few hours, and then every now and then I had to let them go outside the hospital with a cigarette. That trial never was completed. However, at that time, we found two things. We found that in small babies that are hypoxic, the umbilical artery Doppler was showing absence of the end diastolic flow. And we found, and Binay Arabin is here, and Kalia Bilardo, were contributing to this, that in babies that were small and hypoxic, the middle cerebral artery, or at that time they were measuring the carotids, where the PI was decreased. We dreamt for a minute that instead of assessing fetal size, we should be assessing Doppler and looking at this cerebroplacental ratio in identifying babies that are hypoxic, because the vast majority of stillbirths, as you have seen, are not small at all. Unfortunately, in a study involving 47,000 pregnancies that were screened routinely against the recommendations of my government, at 36 weeks, we found that unfortunately that is not very useful. And those are the blues and the reds on the right, showing the detection rate and the false positive rate for a CPR below the 10th centile. So research needs to continue along new lines to identify the non-small babies that die at least a term. In 2002, we decided to do a very simple experiment. The reason why I went into ultrasound is because I was taught in a previous generation by teachers that had the delusion of being Leonardo da Vinci's, that obstetrics is an art. And because I was completely disastrous in art, I thought that there was no hope for me at all. So in 2002, we took 500 women, and we asked the artists amongst the midwives and obstetricians to assess the fetal head position. And we said we will immediately afterwards do an ultrasound scan, and if the digital examination assessed position was more or less within 45 degrees of, within 90 degrees of what the ultrasound is, then it's okay. We found that at 3 to 4 centimeters, the artists were getting it wrong at about 80% of the time, and at 8 to 10 millimeters in 55% of the time. Subsequent studies in the last 10 years, with the ambition of investigating the value of ultrasound in labor, have looked at things like the angle of progression. Very, very good research, and that must continue, and you will find out whether this is going to turn out to be useful or not. But it is absolutely critically important to accept the reality that the artists that run labor wards are completely incompetent in defining the fetal head position, and they should be doing so at least before they put these metals around the baby's head to pull it out. I know from my research fellows that go on to work on labor wards that not only are they not encouraged to do so, but they are strongly discouraged and they are looked down at because they are not good in obstetrics. But it's not an accident that that is the case. It is exactly because in 2011 and in 2017, updated guidelines on how to carry out instrumental deliveries, spend enormous amount of time telling you how to wash your hands, how to dress up as a clown, how to place the woman in the lithotomy position, how to explain to them and give them disinformed consent on what you're about to do, but there is not a single word of ultrasound in the labor ward. I will come to the last part of my lecture, to your delight. And that is the slide that will continue to be shown for generations to come, because it is really good for making the audience cry. 1 million babies die every year in the world because of prematurity. It's very sad, and prematurity is and remains and will continue to remain and increase as the major cause of death and handicap in obstetrics. And in India, it is because the people are poor, and in Africa, it's because the people are dying from infections, and in America, it's because they keep voting for Trump. The question now is, can medicine do anything more than a social revolution? The answer is yes, it can. 30 years ago, we established, and others, that you can, in the second trimester of pregnancy, measure the cervical length. And in women that are likely to deliver in the subsequent few weeks, the cervix is shorter. We established what is normality. We established the relationships between cervical length and the risk of preterm birth. We developed algorithms, and you would have thought that this may be useful. Well, something is useful only if there is an intervention that can prevent the condition that you identified as being at high risk. In 2004, we identified those women that had a short cervix. We randomized them into a group that had a cervical cerclage, Shirotka, and another that did not. And unfortunately, we found that that did not reduce the risk of prematurity unless these women had had a previous preterm birth. In 2007, out of sadomasochism, we carried on doing another trial, identifying the high-risk group because of a short cervix, and now giving them vaginal progesterone. We found that that would reduce the risk by about 30 to 40%. Roberto Romero did the same in a different population and found very, very similar results, and he published a meta-analysis combining the two data, establishing that in women with a short cervix, progesterone reduces the risk of preterm birth by 35%. Bini Arabin, a good friend of mine, has been running after me and telling me off for years that I did not check whether her Arabin pessary works. We planned at the back of a packet of cigarettes with Elena Carrera and Bine in Barcelona a trial that showed that it was fantastic in reducing the rate of preterm birth. We repeated the study, and unfortunately, we found that not to be useful. But it doesn't really matter. What does matter is that we absolutely know how to measure cervical length. We know that the cervix is short. You can give something to these women, and we can substantially reduce the risk of preterm birth. National Screening Committee, 2015. Universal screening for risk of preterm birth is not recommended. We do not have a standardized normal measurement. They're wrong. There's uncertainty over the timing of the test at 9 o'clock in the morning. They're wrong. They are uncertain of the performance. We absolutely know what is the performance. There is not enough evidence that vaginal progesterone prevents preterm birth or death, disability for the baby. They are wrong. I will finish. There have been many, many developments. I have been biased, as I said, around the ones that I observed. Many of you have contributed enormously. The real question for me is, why is it major discoveries are not finding their application into clinical practice? I want to make 2 points. I want to beg those that are involved in the ultrasound of obstetrics and gynecology to prioritize in publishing good studies, and they must not fall into the temporary delusion of improving their citation index by publishing again and again Delphi statements and meta-analysis of badly conducted studies and various guidelines by self-proclaimed experts. This is anti-research. It is very insulting to me that I will spend millions of pounds, thousands of patients to be screened, to carry out a trial, and somebody will turn up and get a 2x2 table and mix it up with another 5 useless studies, and then be the person to be quoted for an advance because they did a meta-analysis that they pressed a button to download some cheap software from the internet. As far as the ISWOG is concerned, I remember with Professor Campbell on the 9th floor of King's 30 years ago. We were discussing the necessity to form a society, the ISWOG Society. The discussion was, we are inhibited by the existing dinosaurs into giving the dynamic of this new field that it deserves. And we identified one critical problem. You cannot possibly be a good obstetrician and gynecologist unless you know how to do ultrasound. How can you be a good doctor if you are completely blind to what you are looking for? We failed. We failed in the last 30 years to address the real issue of how to get rid of the dinosaurs. Because the vast majority of obstetricians and gynecologists in the world, especially those that by accident, because they're not good doctors, they find themselves in writing all of these important guidelines, they have nothing else to do, they are the ones that would feel deficient if they recognize their deficiency in failing in the last 40 years to recognize the arrival of a new technology called ultrasound. The only solution to this, to achieve extinction of the dinosaurs is to absolutely campaign and insist that nobody should be given a certificate of competence in obstetrics and gynecology unless they spend at least 1 year doing obstetric and gynecological ultrasound. Thank you.
Ja, ja.